Hello and good evening, everyone. Today we will be discussing the anatomy of the liver, gallbladder, and pancreas. But today, specifically, we'll talk about the liver only. Then subsequently, if time permits tomorrow, we may be discussing gallbladder and then the pancreas. And we should know the liver is the largest gland in the body, and it has several important metabolic functions. The liver is the largest organ found in the upper right quadrant of the abdomen. It performs several essential functions such as detoxification, protein synthesis, and bile production, and also storage of nutrients. What is the weight? It's about 1.5 kilograms. Now, it works synchronously with many organs and contributes to the maintenance of basic homeostasis. Now, you should know that the liver is completely covered by the peritoneum, with exception of the bare area of the liver, which is where it is in contact with the diaphragm. Now, if you look at this diagram, this portion is termed the bare area. This is the area that is not covered by the peritoneum, and this area is in direct contact with the diaphragm. This diagram is showing the various anatomical segments of the visceral surface of the liver, which anatomically, this is the left lobe and this is the right lobe. The right lobe is larger, and you have anatomically, this right lobe has the caudate lobe. This is the caudate lobe of the liver. And also in the lower segment, you have the quadrate lobe. These are anatomically parts of the right lobe, but subsequently, you will see how they take a different dimension when talking about the functional anatomy of the liver. Now, the liver is covered by a fibrous capsule known as the Gleason's capsule. It is comprised of a large right lobe and a smaller left lobe, as we described. There are two further accessory lobes that arise from the right lobe, which are located on the visceral surface. That is, if you look at the diaphragmatic surface, which we shall see shortly, you will not see these accessory lobes. These other accessory lobes are the caudate lobe. You should pay attention to this. It has a peculiar anatomy, and the quadrate lobe. So all in all, anatomically, you can say it has two main lobes and two accessory lobes. The caudate lobe is located in the upper aspect of the visceral surface, lying in between the inferior vena cava, this is the inferior vena cava, and a fossa produced by the ligamentum venosum. Now, this fossa is produced by remnant of fetal ductus venosum, so the ligamentum venosum. So it is very important, for multiple choice question. The caudate lobe is located between the inferior vena cava and the ligamentum venosum. Okay? The fossa produced by the ligamentum venosum. Now, I'm paying emphasis on this because it can be twisted with the quadrate lobe in your multiple choice question. So you should have the mental picture. The caudate lobe is located between the inferior vena cava and the fossa produced by the ligamentum venosum. The quadrate lobe is located on the lower aspect of the visceral surface of the liver. It lies between the gallbladder and a fossa produced by the ligamentum teres, a remnant of the fetal umbilical ligament. This is the quadrate lobe located between the gallbladder and the fossa formed by the ligamentum teres. Okay? Separating the caudate and the quadrate lobes is a deep transverse fissure. Now you can imagine this. There is this transverse fissure, okay, known as the porta hepatis. The porta hepatis of the liver is the region that transmits all the vessels, nerves, and ducts entering or leaving the liver, with exception of the hepatic veins. So where are the hepatic veins? How does the hepatic veins leave the liver? They drain to enter the inferior vena cava. We shall see that. So don't forget, structures enter and leave the liver through the porta hepatis, except the hepatic veins. Now, these are the surfaces of the liver. There are two surfaces, the diaphragmatic surface as well as the visceral surface. The external surfaces of the liver are described by their location and adjacent structures. There are two surfaces, the diaphragmatic and the visceral. The diaphragmatic surface is the anterior superior surface of the liver. This is the diaphragmatic surface. It is smooth and convex, fitting snugly beneath the curvature of the diaphragm. The posterior aspect of the diaphragmatic surface is not covered by visceral peritoneum, and it is in direct contact with the diaphragm. It is known as the bare area of the liver. Okay, and you can see the bare area of the liver is seen in both the visceral as well as the diaphragmatic surface. The visceral surface, the posterior inferior surface of the liver, with the exception of the fossa of the gallbladder and porta hepatis, it is covered with peritoneum. It is molded by the shape of the surrounding organs, making it irregular and flat. Now you can see this is irregular because of some certain impressions on that surface. And these impressions are caused by the adjacent structures, which are the right kidney, the right adrenal gland, right colic flexure, transverse colon, first part of the duodenum, gallbladder, esophagus, and stomach. The lobes of the liver. There are 4 anatomic lobes. We said the 2 lobes, the right, which is the larger, and the left, and 2 accessory lobes, as we described earlier on. And of course, don't forget their boundaries, the structures they are lying in between. This is the right, this is the left, this is the caudate, okay, and this is the quadrate. Okay. They are further divided into smaller segments in accordance to the blood supply of the liver. We are going to see the segmental anatomy of the liver, and that is very relevant in your surgical anatomy. The caudate lobe sits between the fissure of the ligamentum venosum and the inferior vena cava. We've talked about this earlier on. Now, all what we saw is the functional and structural anatomy, okay, or the anatomical lobes of the liver. Now we'll talk about the functional division of the liver. You should know that functionally, the liver is divided into 2 by a line that is termed the Cantley line. The Cantley line. Okay, it is termed the Cantley line. And what forms the Cantley line? Now, it is important you understand the significance of the Cantley line. There are 2 important things you need to know about this landmark. It is an imaginary line that cut across the inferior vena cava, porta hepatis, and the gallbladder. And it also signifies the position of the middle hepatic vein. The middle hepatic vein lies along the Cantley line, okay? Now, it divides the liver into the functional left and the functional right lobes, roughly equally. The division of the liver into equally sized functional left and right lobes is done by drawing a line through the midline of the gallbladder and the inferior vena cava. And this line runs through the porta hepatis. as opposed to the anatomical division that results in caudate and quadrate lobes being between the right and the left anatomical lobes of the liver. This division results in the caudate and quadrate lobes being a part of the functional left lobe. Now you can see with this functional division, those two accessory lobes are now part of the left lobe rather than the right lobe. So you have to pay attention to this, because when considering you are asked an MCQ that the caudate lobe is part of the right lobe, you have to understand what they are asking. Is it the anatomic right lobe or the functional right lobe? So you should know that from the functional division, those accessory lobes are part of the left lobe of the liver. Now, this Cantley line or Rex Cantley line divides the liver into two halves: the right hemiliver or the right lobe, or the left hemiliver. And of course, don't forget, it runs through inferior vena cava, the porta hepatis, and the fossa of the gallbladder. Now let's see the ligaments of the liver before going to see the significance of the functional division, where the liver is divided into various segments. Okay. There are a number of ligaments that attach the liver to the surrounding structures. These are formed by a double layer of peritoneum. Now, the falciform ligament. This is the falciform ligament. Okay. It's a sickle-shaped ligament, attaches the anterior surface of the liver to the anterior abdominal wall. Its free edge contains the ligamentum teres, a remnant of the umbilical vein. Now, the coronary ligament, it has anterior and posterior folds. This pinkish signifies the coronary ligament, and you can see it has an anterior and posterior folds. Attaches the superior surface of the liver to the inferior surface of the diaphragm and demarcates the bare area of the liver. The anterior and posterior folds unite to form the triangular ligaments on right and left lobe of the liver. As you can see, these coronary ligaments, they unite to form the triangular ligaments on both sides, the right and the left triangular ligaments. And of course, if you look at the coronary ligaments on the right side, more of the bare area is on the right side as compared to the left side. The triangular ligaments has both the left and the right triangular ligament. The left triangular ligament is formed by the union of the anterior and posterior layers of the coronary ligament at the apex of the liver and attaches the left lobe of the liver to the diaphragm. The right triangular ligament is formed in a similar fashion adjacent to the bare area and attaches the right lobe of the liver to the diaphragm. So you should see how the liver is suspended by this ligament, and the curvature of the diaphragm also keeps it in position. These are, you should know, these are not only the attachments of the liver. The lesser omentum attaches the liver to the lesser curvature of the stomach and the first part of the duodenum. It consists of the hepatoduodenal ligament, okay, extend from the duodenum to the liver, and the hepatogastric ligament, extend from the stomach to the liver. Now, you should know that the hepatoduodenal ligament at this point is attaching to this first part of the duodenum, surrounds the portal triad. If you remember, we discussed the portal triad, the portal vein, the hepatic artery, and the common bile duct. If you remember, we talked about the position. That is something common in your MCQ. If you don't forget, we said the portal vein is what? Posterior. What is right and what is left? If you if you remember, we said the portal vein, this forms the portal triad. Portal vein is posterior. What is right, what is left? Okay, let me leave that to the end of the lecture. Okay. In addition to this support, if you remember, what are the supports? What are the ligaments that support the liver? You remember the coronary ligament, the triangular ligament, okay? Then the lesser omentum has the hepatoduodenal and the hepatogastric ligament. In addition, okay, to this supporting ligament, the posterior surface of the liver is secured to the inferior vena cava by the hepatic veins and fibrous tissue. You should know that the hepatic vein does not exit the liver through the porta hepatis. Rather, posteriorly, it drains into the inferior vena cava. And that also gives an attachment in form of a support, okay? We shall see that. Okay, let's talk about the hepatic recesses or species. Now, the hepatic recesses are anatomical spaces between the liver and surrounding structures. They are of clinical importance as infection may collect in this area, forming abscesses. Now, you should know of all these, the deepest of all these, the deepest, okay, is the Morrison's pouch when a patient is lying in supine position, okay? So, let's see these various spaces. The subphrenic space located between the diaphragm and the anterior and superior aspects of the liver. They are divided into right and left by the falciform ligament. So this is the subphrenic space. You can see it's just beneath the diaphragm, in between the diaphragm and the superior aspect. Now, you know the falciform ligament attaches this liver to the anterior abdominal wall. Hence, it divides this space into right and left. Okay, then you have the subhepatic space. The subhepatic space. A subdivision of the supracholic compartment that is above the transverse mesocolon. This peritoneal space is located between the inferior surface of the liver and the transverse colon. Okay, this is the subhepatic space, and interestingly, this subhepatic space is divided into two portions, the left and right. Okay, and the right is what is termed the Morrison's pouch, a potential space between the visceral surface of the liver and the right kidney. This is the deepest part of the peritoneal cavity when supine. Therefore, pathological abdominal fluid such as blood or ascites is most likely to collect in this region in a bedridden patient. Now let's see more about this Morrison's pouch, because you see it's an important space, deepest, where a bedridden patient is more likely to collect fluid. Now, if you look at this image here, this is the right subhepatic space. Okay, you can see this space. Okay, is subhepatic, and behind that is the position where you have the right kidney. So it's a space. It's also called the hepatorenal rhexis. Okay. Now, if you look at the image on this other image, this is the right subhepatic space. Okay, at this position. This is the bare area of the liver. You can see how all these spaces are communicating with each other. Okay. The posterior right subhepatic space is separated from the anterior right subhepatic space by the transverse mesocolon. The transverse mesocolon. The space communicates with the right subphrenic space. Okay, you can see it communicates up. So you can see collection from the subdiaphragmatic can trickle down to the Morrison's pouch. And it also connects to the right paracolic gutter. Okay, and even the lesser sac, because this is called the foramen Winslow, and you can see from here it can drain into the lesser sac and collect. Okay, so this is called the epiploic foramen of Winslow. So you should know the spaces it connects to. It connects the subdiaphragmatic or subphrenic, the right paracolic gutter, and it also connects to the lesser sac via the foramen Winslow. Morrison's pouch is also known as posterior right subhepatic space or the hepatorenal fossa or subhepatic rhexis. All these are synonyms. It's a potential space that separates the liver from the right kidney. You can see this is the right kidney. Okay, and you can see how deep this could go. Okay, now let's talk about the segmental anatomy of the liver. Now, you should know that the liver is divided into 8 functional independent segments, okay? Each segment is independent in that it has its own vascular inflow, outflow, and biliary drainage. And each of these can be resected off the liver without affecting the other segment. So a disease segment can be independently resected as segmentectomy without affectation of other part of the liver. Okay, that's why you can see even up to 80% of the liver can be diseased and the liver is still functional because of this segmental anatomy. Okay, now you should know that in the center of each segment is a branch of portal vein, hepatic artery, and a bile duct. So at the center of each of these segments is a portal triad. And you should know these segments is divided into, how is it divided? You remember the Cantley's line divide this into 2 segments, the right and the left lobes, functional lobes. And we said that this Cantley's line is at the position of where? The middle hepatic vein. So the right hepatic vein and the umbilical plane at the position of the falciform ligament. You can see how it divides into 3 planes, 3 vertical planes. Okay. And these are subsequently divided into 2. Okay, so you have this umbilical plane divides into a lateral segment, a medial, lateral and medial. Okay, then you have anterior and posterior. Okay, so each of these is now further divided into 2 segments. Okay, that is making 8. Each functional lobe can then be further subdivided into their respective sectors. The functional left lobe, this is the left lobe now, is divided into left lateral and left medial. Okay? Along the attachment of the falciform ligament and through the fissure for the ligamentum venosum and the ligamentum teres. The left lateral lobe lies to the left of the fissure of the falciform ligament, which we just described, while the left medial lobe lies between this line, okay, and the main demarcation that separates the liver into the functional lobe. So you can see how the left lobe is divided. Okay, we already mentioned this in the previous slide. Similarly, the functional right lobe is divided into the right medial and the right lateral sector by the oblique line that passes anterior posteriorly from the midpoint of the right lobe to the vena cava group. So this is also divided. This is also called medial or lateral, but more commonly they are called right anterior and right posterior, more commonly. It should also be noted that because of the rounded shape of the lateral border of the liver, the right medial and right lateral sectors are sometimes referred to as the right anterior and right posterior, respectively. Now, we've not talked about this segment. If you look at how this portal vein divides now into the right and the left portal, dividing this into two halves, the upper half and the lower half. Now, this giving it 8 segments from 1 to 8. And how are they numbered? They are numbered in a clockwise manner, with the caudate lobe being segment 1. And of course, this caudate lobe is at the visceral surface. You can't see it from the diaphragmatic surface. Okay, now this is caudate lobe number 1, segment 1. Okay, then you have the segment 2. If you now go in a clockwise manner, caudate is segment 1. Then you have segment 2. You know the left lateral has upper and lower. You have segment 3. Then 4 now. This left medial has A, 4A, and 4B. Okay? Then you see 1, 2, 3, 4. A and B, 5, 6, 7, 8. So it goes in a clockwise manner, don't forget, with caudate lobe being segment 1. Each sector is subsequently divided into 2, producing 8 hepatic segments. Segment 1, the caudate lobe, is the posterior superior part of the left medial sector. Segment 2 is the posterior superior segment of the left lateral sector. So it's the upper part of the left lateral, if you remember. Segment 3 is the anterior inferior part of the left lateral. So 2 and 3 are part of the what? Left lateral. While 4 is the medial that is further divided into A and B. 4 includes the entire left medial lobe anteriorly and the quadrate lobe viscerally. So you should know that quadrate lobe is part of what? Segment 4, while caudate lobe is part of what? Segment 1. Okay, it is further divided into segments 4A and 4B. Okay, segment 4A lies superiorly, while segment 4B lies inferiorly and corresponds to the location of the what? Quadrate lobe. So 4B corresponds to the location of the quadrate loop. Segment 5 forms the inferior part of the right medial sector. Okay, segment 6 is the inferior part of the right lateral. If you remember the image, okay, we drew, you see, right medial, okay, right lateral, okay. Segment 7 is the superior aspect of the right lateral. Superior aspects of the right lateral, but this is superior. Superior right lateral. And segment 8 will now be what? Superior aspect of the right medial. Superior aspect of the right medial. So these form all the various segments, and each of these segments has its own blood supply and its biliary drainage, such that it can be removed independently via segmentectomy. Now, these are the various anatomic, the various lobes, segments. You see one is on the visceral surface, is the caudate lobe. You can see 2, 3, 4A is superior, 4B is inferior, 5, 6, 7, 8. Don't forget, it is counted in a clockwise manner, okay? In a clockwise manner. Now, if you are asked the position of any segment, I believe if you have the mental picture, you know what segment they are talking about. If they say segment 4B is diseased, you know they are talking about the quadrate lobe. If they say segment 1 is diseased, you know they are talking about the caudate lobe. If they mention segment 2, 3, you know is the superior left lateral, and so on. Now, the microscopic anatomy of the liver is also very important. If you just take a segment from this, microscopically, the cells of the liver, known as the hepatocytes, are arranged into lobes. These are the structural units of the liver. So the lobules are the structural units of the liver. Each anatomical lobule is hexagonal in shape and is drained by a central vein. Okay. Each hexagon, you notice that there is a central vein on each hexagon. Okay. Now, at the periphery of the hexagon are 3 structures collectively known as the portal triad. Okay, at the periphery of each hexagon, you have the portal triad, the arteriole, a branch of the hepatic artery, entering the liver, a venule, a branch of the hepatic portal vein, entering the liver, and the bile duct, a branch of the bile duct leaving the liver. So you can see 2 vessels are bringing blood to the liver, and the bile duct is taking bile away from the liver. So what vein takes away blood from the liver is that central vein. Okay? It takes blood away from the liver. Both the hepatic artery and the portal vein brings blood to the liver, and the bile duct takes away product of metabolism, bile, away from the liver, and the vein, central vein, that all coalesce to form the hepatic vein, drains blood away from the liver. And you should know these ones are the structure that pass through the porta hepatis. The portal triad also contains lymphatic vessels and vagus nerve, parasympathetic fibers. Now let's see the vasculature of the liver. The liver has a unique dual blood supply, the hepatic artery proper that brings up 25% of blood, supplies the non-parenchymal structure of the liver with arterial blood. It is derived from the celiac trunk. The hepatic portal vein, 75%, supplies the liver with partially deoxygenated blood, carrying nutrient absorbed from the small intestine. So the portal vein is coming from the small intestine, but with partially deoxygenated blood. It's the dominant blood supply to the liver parenchyma. And also, it allows the liver to perform its gut-related functions, such as detoxification. Now, you should know that 75% of this blood is coming to the liver via the portal vein. Even though it is deoxygenated, partially deoxygenated, but if you look at the amount, this 75% will provide 50% of oxygen, and the 25% will provide 50% of oxygen. Even though you know this is slightly deoxygenated, but because of the amount and the flow is higher than this 25%, so the total amount of oxygen is providing is roughly of the same amount. The venous drainage. The liver is achieved. The venous drainage of the liver is achieved through hepatic veins. Okay? The central veins, if you remember in that hexagonal shape of the hepatic lobule, form collecting veins, which then combine to form multiple hepatic veins. These hepatic veins then open into the inferior vena cava. Don't forget, there is the left, the right, and the middle hepatic vein. Now, if you go back to this diagram, okay, you realize that there is a right hepatic vein, there is the middle hepatic vein, and there is the left hepatic vein. The left and the middle, sometimes they unite and drain into the hepatic vein. Then they drain into the inferior vena cava, while the right drains into the inferior vena cava. Now, there's a peculiarity of the caudate lobe of the liver in that it drains directly into the inferior vena cava. That is one peculiarity of the caudate lobe. One, it drains directly into the inferior vena cava, while other segments drain into one of these tributaries, right, middle, and left. And secondly, another peculiarity of this caudate lobe is that it receives supply from both the left and the right branches of the portal vein. Okay, so it can be regarded as a separate entity on its own. Segment 1. Nerve supply. The parenchyma of the liver is innervated by hepatic plexus, which contains the sympathetic celiac plexus and parasympathetic vagus nerve. So the autonomic supplies the liver. The sympathetic component is from the celiac plexus, and the parasympathetic component is from the vagus nerve. These fibers enter the liver at the porta hepatis and follow the course of branches of the hepatic artery and portal vein. The Gleason's capsule, the fibrous covering of the liver, is innervated by branches of the lower intercostal nerves. Okay, you can see this somatic nerve will give pain. Distension of the capsule results in sharp and when localized pain. So these causes of pain here are from different nerve roots, okay? The intercostal nerves, which are somatic. Lymphatic drainage are both anterior and posterior aspect of the liver, okay? The lymphatic vessels of the anterior aspect of the liver drain into the hepatic lymph nodes. These lie along the hepatic vessels and duct in the lesser omentum, okay? And empty into the celiac nodes, which in turn drain into the cisternal chyli. Now, all the anterior aspects of the liver drain into the celiac group of lymph nodes, which also drain all the lymphatics from the stomach. Okay, and it subsequently enters the cisternal chyli to empty into the thoracic duct. The lymphatic from the posterior aspect of the liver drain into the phrenic and posterior mediastinal nodes, okay, which join the right lymphatic and thoracic ducts, okay? So this is a more detail of the lymphatic drainage of the liver. Now, deep, we said they are both superficial and deep. And we briefly mentioned how the group of lymph nodes they drain into. Now, some clinical relevance of the liver. When patients have chronic liver disease, there are some chronic stigmatas for chronic liver disease, okay, which of course, you know, they have jaundice, parotid swelling, okay, distribution of hair patterns, and several other conditions which you should know as stigmata of chronic liver disease. When patients have a raised portal hypertension, there will be, you know, there is going to be portosystemic shunt. And of course, we discussed that previously. And of course, liver biopsy is something that is also taken in patients with abnormal liver function tests, liver malignancy, hepatitis following transplant, and so on. If a patient has abnormal clotting profile, liver biopsy is contraindicated. Okay, so we're going to stop here, and if you have any question, you can ask a question. Any question? Okay, I believe you don't have any question. So we are going to stop here. Then we'll continue with anatomy of the biliary and pancreatic, the biliary tree and the pancreas. So thank you all.